Welcome all of you to the 34th live webinar on orthopedic principles. We are back again with Professor Bijayendra Singh from United Kingdom. He's also professor at Canterbury Christchurch University. Today he's going to enlighten us on common shoulder topics for the fellowship exam. Over to you, Professor Singh.
Thank you, Hitesh. And once again, a big thank you for organizing all this. I'm sure the guys and girls who are looking to do the fellowship exam will be ever so thankful to you. So again, as I did last time, rather than focus on one particular topic, today we'll try and cover 4 topics maybe on the common things that you're likely to encounter in the fellowship exams. And this is likely to come up either on your adult pathology viva or on an intermediate case. Following the presentation, you may go into discussion on one of these topics. So look at this. And again, we'll try and stick to the similar principle what I discussed last time, especially for the viva scenario. You will always be given a prompt, and then the discussion can go on from different directions from that point. So looking at this X-ray, what is this? So this is an X-ray. Sorry, I'm just trying to. So looking at what we said last time. So what is this? So this is a plain radiographs on the right shoulder, PA view on a patient, which shows where I can see there is a reduction in the acromial space, subacromial space. There is overriding of the humeral head just under the riding right up to the acromion. There is degenerative changes. The Shenton's arc of the shoulder joint is broken. And my working diagnosis here is a rotator cuff arthropathy in this gentleman, in this patient. So I would presume that this is on the slightly older age group patient. The question is what relevant history to take. So I would be prompted to ask about the history. So I would like to take the onset of the pain. How long has it been going on? How does it affect the patient on a day-to-day basis? Is there any night treatment? Any history of injury to the shoulder? And especially any treatment if the patient has had, including physiotherapy, another non-operative intervention, any previous history of surgery that if the patient has got. In the history, it's quite important as you look to formulate the plan for treatment is the medical history of this patient. Most commonly, these patients are going to be in the older age group patient and likely to have multiple medical comorbidities. So you want to know what, and if they are on any medication, especially if they are on any blood thinners, and if they've got any allergies to the medication. This should be the standard format of any history taking for any patient. So that we've done. What else to examine? So if you're in a clinical scenario, a case-based patient, then you'll be asked the examination. So examination, particularly you're looking for, on inspection, you're looking for any scars around the shoulder, be it arthroscopic ones or open scars. The open ones are easier. The arthroscopic ones may be a bit difficult, and hence it's important to check again whilst you are, if you've forgotten in the history, there's no harm in asking the patient if they've had any surgery to point out to any scars if they have. And if you see any scars, you always ask for, are there any other scars, so that you don't miss out on important scars, especially if they are in hidden areas, i.e. towards the armpit, around the shoulder, or in the groin area if you're dealing with a lower limb case. You look for any muscle wasting, especially the supraspinatus and infraspinatus. And more importantly, you would get the patient bare or above the waist. I generally tend to examine with the patient facing a mirror and examine from the back of the patient so it's easier to see. After that, I would go through my routine shoulder examination. So once you've done your inspection, I would do the palpation. And again, remember, this is a fellowship exit exam. These are not your MBBS or MRCS exams where the examiner is interested in the whole thing, that you do step by step and rule out everything. So once you've done your inspection, you go on to palpation and you palpate the points where it's relevant. So you start with the sternoclavicular joint palpation, then look for any tenderness over the clavicle, the AC joint, the greater tuberosity. Now at this stage, you may sometimes find what's called as a humeral, anterior humeral escape, which is seen in cuff tear arthropathy as the anterior anterosuperior structures of the shoulder joint becomes a bit lax and the CA ligament becomes incompetent. The humeral head may start to appear. Sometimes it may be seen at rest. More commonly, it is seen when the patient starts to move. Once you've done your palpation, then I move to a combined examination, which includes movement and power testing at the same time. So you get the patient to move their arm forward, so you're checking for the elevation in that direction. First, ask them to do actively, and then with the point where they stop, you can use your hand to see how much passive movement they've got. And then when they get up to the full height, then you ask them to bring their arm by the side. So that gives you your abduction. And as they come down, you need to check for a couple of things. A, how smooth their movement is. And when they're coming down, you do your strength testing for the supraspinatus as well as the deltoid. After that, you do either your internal rotation, active movements, and then once the hand is at the back, examine for the subscapularis. There are various ways of how you examine, sort of test the suprascapularis, either the pull-off test or the bear hugger test or the belly press test, as it's called. And then finally, you do your external rotation. And as you go along doing the movements, you also test the power in these muscles. So that's done your examination. What's the likely cause for this? The most common cause is underlying rotator cuff tear, a long-standing rotator cuff tear, which causes the shoulder to become imbalanced and leads for the humeral head to migrate proximally, and the deltoid then takes on the main function of the abduction. But because of mechanical disadvantage, the humeral head is pushed against the acromion, and you may eventually see thinning of the acromion, often called as the acetabularization of the glenoid along with the acromion. Now, how are you going to investigate this? Clearly, the investigation is not just for the shoulder, it's for the patient as a whole. So for initial management of this patient, I think a plain X-ray, this is enough information. You would say that at this stage, you would start non-operative intervention to begin with. And again, as I said in my last week's chat, it depends. And that's why it's important to listen to what the examiner is saying. So if you've been asked that this is an 80-year-old patient who has had 6 months of non-operative treatment for the shoulder pain, then you don't start sending the patient back for non-operative treatment. Then you take the next step. So we discussed 2 scenarios. So the first scenario is that this patient hasn't had any treatment. And in that situation, what you would do, if the patient hasn't had, then you'd give them, and this applies for any painful condition, is rest, non-steroidal, as well as some painkillers, activity modification, physiotherapy, and plus minus a steroid injection. Now, although steroid injection is controversial to be used, especially if you're dealing with a tendinopathic kind of problem, or perhaps arthritic conditions of the hip and the knee, but certainly in the older age group population, a single shot of steroid injection is not going to cause any harm. Having said that, you must remember that if a patient has had steroid injection, then arthroplasty should be avoided for at least 3, preferably 6 months after the last injection has been done. So in the first situation, you would say you would do all this non-operative treatment, send the patient for physiotherapy. Now, if you're doing well, you may be asked about what physiotherapy you're going to do, and then you need to know some of the basic rotator cuff strengthening exercises. And that's when you're looking at a score of a 7 or an 8. If you've been asked those questions, then you definitely pass. Second scenario is where you were given that this patient has had previous non-operative treatment and is suffering with a lot of pain and is keen to proceed with further steps. So in that situation, I think it's reasonable to get a CT scan done of the shoulder. Now, on this particular one, you may not require it if the wear does not look significant, but often if we've been caught out, or surgeons have caught out with the wear, especially the posterior wear. So I think a CT scan of the shoulder to look for glenoid morphology is a reasonable investigation to check at this stage. Plus, obviously, you're going to investigate for any other things which may be required to make the patient fit for surgery. So what are your options at this stage? So the scenario given to you is that this is an 8-year-old patient who has had non-operative treatment, is now struggling with his day-to-day activities, is fit and well, and you're going to proceed. So the answer would be that I would offer this patient a reverse polarity shoulder replacement, as I can see that this patient has got no rotator cuff left in place, and hence an anatomic shoulder replacement is less likely to give him or her a predictable pain relief and function after the procedure. What are the principles of reverse polarity shoulder replacement? The principles are that the center of rotation is made distal and also offset laterally or medially, depending on the type of prosthesis that is used. And this allows the deltoid to be tensioned, and the deltoid becomes the prime mover of the shoulder. At this stage, then the discussion could go, let's go through the approach. So the approach how would be that in an appropriately consented, marked and anesthetized patient, I would put the patient in a beachhead position. I would draw up my landmarks, the coracoid process, the axillary fold, and the deltoid insertion. And my incision runs obliquely, just lateral to the coracoid process, going away from the axillary fold and into the biceps groove, as this will allow me to extend the incision if it is required. I do my skin incision and perform hemostasis. Once I've done this, I would look for the cephalic vein. In a virgin shoulder, usually there is a fat pad that is present in the deltopectoral groove, and this will lead to me to the cephalic vein. I generally tend to take the cephalic vein whichever way it's easy to go. More often than not, it ends up medially. The textbooks say that you try and take it laterally, as there are tributaries that are present and less likely and should be avoided to be torn or need to be cauterized. But in practice, I have not seen any problems with that. So again, I would say whatever you have seen being done or whatever you do in your own practice, once you retracted the cephalic vein, then generally I would identify the pectoralis major tendon as well as the deltoid. At this stage, I would do a subdeltoid release, putting my finger onto the subdeltoid space. And if the shoulder is stiff, I may release part of the anterior deltoid insertion into the humerus. Again, I would also release about 1 centimeter of the pectoralis major tendon if the shoulder is stiff, especially in internal rotation. At this stage, I would palpate the axillary nerve as it runs under the undersurface of the glenoid by putting my finger under the conjoint tendon. Now, the easiest way to identify the conjoint tendon is palpating the coracoid process. Once I palpate the coracoid process, I find the conjoint tendon, and if I run my finger on the medial side of this, then I will be able to feel the axillary nerve. What do you do with the axillary nerve? I generally just tend to feel the axillary nerve and leave it in place in primary cases. In revision scenarios, I take time to isolate and dissect the axillary nerve and protect it. And once you've done this, I'll release the coracoid acromial ligament, and this will then lead you on to the subscapularis. At this stage, you put soft self-retainer retractors, externally rotate the humerus, so that puts the subscapularis under tension. I would identify the 3 sisters, the vascular supply, the small arteries onto the subscapularis muscle. I'll put a stay stitch, and then I generally tend to peel off the subscapularis from the bone. The options are either doing a tenotomy or an osteotomy of the lesser tuberosity. Again, depending on what you've seen is your preferred option. There is no difference in the outcomes or the healing of the tendon that is seen following either of the approaches. Once you release the subscapularis, sorry, before that, the easiest way to identify this is to identify the long head of biceps if it is present. The long head of biceps will lead you to the rotator interval, and that makes identification the top of the subscapularis and the peeling of the subscapularis much easier. At this stage, I tend to tenotomize the biceps, leave a little stump of the long head of biceps attached to the glenoid, so it's easier to orientate the superior inferior direction of the glenoid. Once you've done the release, peel of the subscapularis from the humerus, then I do what we call as a 360 capsular release. This involves release of the subscapularis from the anterior surface of the glenoid, inferior capsular release, and the posterior capsular release if possible, taking care, especially at the inferior side, that you do not do any damage to the axillary nerve. Now, it's important to remember that in the arthritic shoulders, especially if the patient has got cuff tear arthropathy, the axillary nerve is much closer than it would be normally. So one needs to be very careful when doing this dissection. Once this release has been done, and then you use the technique as described by the manufacturer, preparing the glenoid and the humeral surface to put your implants in. So that's done your deltopectoral approach. If the deltopectoral approach is being used for a fracture, then obviously you don't need to peel off the subscapularis, but the rest of the approach is the same. The discussion then could stop or could go into if you're doing a reverse shoulder or if you're doing an anatomic shoulder, is what type of glenoid is used. So the discussion about metal-based versus all polyglenoid, as well as keeled versus peg glenoid. So at present, the all polyglenoid is still considered the gold standard. There are some new designs with metal back glenoid coming into market. The problem with metal back glenoid is that the thickness of the glenoid increases, and this can cause overstuffing of the joint and has shown to cause more problems than the all polyglenoid. If you're using an all polyglenoid, whether you use a keel prosthesis or a peg prosthesis, a slightly individual choice. But again, if you look at the results, then the peg glenoids do show a better result than a keeled glenoid. On the humeral side, the stemmed or stemless will depend on the age of the patient and the quality of bone. Uncemented versus uncemented has not shown to be any difference, any different than others. So I think for the shoulder arthritis, certainly for the cuff tear arthropathy, it's a different, it's the same. Now, going along the same, this is onto similar principles, but the difference is that this is X-ray, both AP and lateral view on the shoulder, showing glenohumeral osteoarthritis. Here, there is a reasonable subacromial space. Now, the accepted normal height, in which the magnification is known, the lower limit where you think the cuff may be intact is about 7 millimeters. So on this one, it looks that it may be okay. But in arthritic shoulders, if they've got primary glenohumeral joint arthritis, in those situations, even if the patient has got a cuff tear, sometimes the humeral head does not migrate proximally. And also, this is a very typical appearance with goatee beard that is seen at the inferior side of the humeral head. To get better points, remember, you can see this patient has also got a pacemaker, and that is relevant for two reasons. One is that it's likely, almost invariably, that this patient is going to be on blood thinners, which will need to be stopped before the surgery. And secondly, the use of diathermy in this patient with the pacemaker is limited. And also likely that this patient may have an ICD fitted in. In that situation, you will need to get in touch with the cardiology department or the cardiologist who has arranged this, as this will need to be turned off while the patient is having the surgery. In this situation, nowadays, especially for patients between the age of certainly 50 to 70, if it's a primary glenohumeral joint arthritis and we're contemplating an anatomic shoulder replacement, then along with the CT scan, I would certainly get a MRI scan, as both the clinical examination, so certainly the clinical examination is not going to be as good in this patient, partly because of stiffness and partly because patient will be in, or may be in pain, and that will reduce the reliability on the clinical examination. So all going okay? Hitesh, all okay?
Yes, yes, please carry on.
Okay. So another scenario, this is most likely to be on the Viva table. So these are clinical pictures. So this is a picture of a shoulder. So this is a arthroscopic pictures on the shoulder, and what I can see is quite inflamed glenohumeral joint. I can see on the top picture, I can see the humeral head at the top and the glenoid at the bottom part with inflamed synovium and some thickening. On the lower part, what it appears like to be a radiofrequency probe that I can see. Looking at this picture, without any more history, my presumptive diagnosis would be a capsulitis or a frozen shoulder. I would like to know from the patient the history of the pain, how long the patient has had it for, and how it is affecting. Presumably, as these are intraoperative pictures, this patient is on having surgery for what looks like a frozen shoulder. The frozen shoulder is wherein the shoulder joint becomes stiff, and it goes through a stiff and painful. It goes through 3 stages: a freezing phase, a frozen phase, and a thawing phase. The freezing phase usually can last 6 to 8 months and is very painful. This is usually idiopathic, but can often be triggered by a minor trauma or jarring of the shoulder. The disease is more commonly seen in diabetics, patients who have underlying inflammatory arthropathy, raised cholesterol, Parkinson's, and Dupuytren's. It also tends to run an aggressive course in diabetics. Typically, in this stage, the patient will present with pain getting worse with any attempted physiotherapy. They also have quite severe night pain. In the second stage, through the frozen phase, is when the pain tends to start to ease and the stiffness becomes the main problem. And this can last for 12 to 18 months, after which the shoulder starts to ease out, pain gets easier even more, and the movement starts to return. Now, as I understand, the classic teaching is that this is a self-limiting condition which resolves on its own over 2 to 3 years. But studies have shown that this is not the case, especially in diabetics, that patients still have residual stiffness. Essentially, it is a self-limiting condition, and the aim of treatment here would be to make the patient comfortable. If the patient comes in at an early stage, then one, depending on the level of pain, one would consider a hydrodilatation release with or without a gentle mobilization under anesthetic. There are various studies, and this is what you will need to read up, which has shown that hydrodilatation or hydrodistension or glenohumeral joint release, whichever way you want to do it, has shown that is quite efficacious in relieving the pain, as well as the movement in the early stages. Once the patient has gone through the early acute phase, and if pain isn't an overbearing symptom, then it's less likely that the hydrodilatation is going to work. But even in those situations, one can try. I certainly offer that to the patient with the understanding that it may not work, but it's a simple procedure with little rehabilitation after that. If that is not acceptable, then the next step is to certainly in my hand, would be to consider an arthroscopic capsular release, and that is what would be the fellowship answer, is to do a arthroscopic capsular release. And when you're going to go down the arthroscopic route, which we'll discuss a bit later, maybe in the next session, would be the portals for the arthroscopy. The arthroscopic capsular release is useful when the patient is in the frozen phase, when pain is in the overbearing symptom. And after that, you would consider, you would have the rehabilitation after that. So look at this, the question here will be, look at this picture. These are images on a 24-year-old patient who has presented with history of dislocation of his shoulder. Now, you may think that, you know, now that the history has been given and they've been told that this is an MRI scan, that you've been given the answer. But just remember one thing, that during the exam, it's not necessarily just about the knowledge. It's often the pressure of the exam which gets to you. And what I've seen is when I do this hot seat viva, the person who's in the hot seat tends to forget, while the candidates who are sitting in the audience, they all know the answer. So it's the pressure of the situation which causes. So anyway, so these are axial sections of an MR arthrogram. If you're clever enough, you may want to say whether it's a T1, T2 fat sat images. If you're not, then I suspect you will not be passed or failed for not saying that. Okay, so here you can see there's axial sections of the MR arthrogram. Why MR arthrogram? Because I can see some fluid distension, whether this is arthrogram that is performed by a radiologist or the patient has had a recent dislocation. So it can be an arthrogram because of the blood within the joint, but there is an arthrogram. The things that I can see on the top left-hand corner, I can see there is a Hill-Sachs lesion. There is some bone edema. On the top right-hand corner, I can see there is a loose fragment which looks like an osseous or an osteocartilaginous fragment lying posteriorly. At the front, I can see the disruption of the capsule and the labrum, perhaps a small avulsion from the bone. And looking at the top two images, I can see there is some dive within the soft tissue outside of the capsule. So this is suggestive that this is a radiologist performed arthrogram. As you can see at the top right-hand corner above the subscapularis. On the bottom right-hand corner, again, I can see that loose fragment which is extended and further damage to the inferior part of the labrum, and certainly even the bony labrum looks blunted, suggestive of a osseous or osteocartilaginous labral fragment, a Bankart tear. And on the bottom left side, I can see there is some fluid along the biceps and the blunting of the anterior inferior aspect of the glenoid with a loose or a detached labrum. Now, you're not going to be asked, how do you know if this is superior or inferior? Again, the shape gives it away. If you want it to be pedantic, then you would always have the other views to compare. But at the fellowship exams, this is a given thing that, and that you would be able to identify that, and you would not be passed and failed for this. Now, so based on this MRI scan, I would say that I think this patient is most likely to have a recurrent dislocation or an instability with what this patient is presenting. History-wise, I need to know a few things. Age of the patient, first time the dislocation happened, the last time the dislocation happened, how many episodes of dislocation has happened, how did the first episode happen, and how often has it come out, and has the patient needed to attend a hospital emergency department for relocation? Is there any occasion where the shoulder has dislocated in the sleep? All these help you with identifying the degree of laxity of the shoulder joint. Then you need to know if there is any other other joint laxity, whether the patient has ever been diagnosed with this any underlying collagen disorder. If the other shoulder is affected, have they had any procedures prior to this? Again, epileptic history would be relevant, although in epilepsy you tend to see a posterior dislocation, but you can get anterior disruptions as well. So that's about the history. And again, don't forget, if it's an intermediate case, your medication history and your allergy histories. What to examine? So again, examination follows, in my hands, there's two broad groups of how you perform the shoulder examination. One is for a painful condition and one for the instability style of pattern. For the instability, again, I would examine either from the back of the patient or from the side. In patients with instability, after an inspection, looking at the things that we mentioned in the first picture, is to look for the excursion of the rhythm of the shoulder joint, because sometimes the patient may avoid certain movements to try and avoid the dislocation. Now, from the shoulder instability point of view, there are two tests that are important. One is the apprehension test. Now, apprehension test isn't the apprehension in the shoulder. The apprehension is in the face of the patient. So the way you do is, when you're doing the apprehension test, is to look at the patient's face rather than focus on the shoulder. And sometimes it's even when you feel on the shoulder. So what you do for apprehension test is you you start your arm in that position, because the patient is aware that the abduction and external rotation is the weak point for them, so they may not like it. So what you will notice is two things. One is, as it goes into more abduction and external rotation, you may feel a resistance as you move the arm back if you rotate it out, or you have a look at the patient's face and they may not like what you're doing. So that's all you need to do. You're not attempting to dislocate the shoulder. So once you've done your apprehension test, then you do your Job's relocation maneuver. Now, some people do it supine, some people do it sitting. I certainly do it sitting down, patient sitting, relaxed on the chair, and essentially do your, I do my apprehension maneuver and the Job's maneuver at the same time. So you do your apprehension test and then bring the arm back forward. Then what you do is you put your hand and push this humeral head into the socket. So you're trying to keep the humeral head in the socket. So the pressure is not on the head, it's on the proximal part of the humerus. And you're trying to push the humeral head back posterior into the socket to keep it there. And if that is relieved, then that's a positive test. Again, it's quite subjective. It may or may not be present. Two more things to look for is the sulcus test or the drawers test. And the drawers test, they can be difficult, especially if you've got a muscular patient. And I wouldn't necessarily put a lot of weightage on testing that. If you are going to do the draws or the sulcus test, the best is to get the patient to lean over a table with the affected side free and the unaffected side supporting the body onto the table. And what that does is unlocks the shoulder itself. Clearly here you need to check for any hypermobility or ligamentous laxity. So you do your Baton score and check that that's within limits. Now, that is about the investigation. The causes, again, depending on where this discussion is going, you need to be aware of the Stanmore triangle, which is quite similar to Hitesh's triangle of orthopedics principle, where you've got your traumatic, atraumatic, and then something in between the two, and patients in the atraumatic group can go into the traumatic group, and how you're going to manage. The next is the principles of management. Now, after the first episode of dislocation, so in this, if you're given on a viva, you could be said that these are following a first episode. So in following a first episode, I think vast majority of the shoulder surgeons, in vast majority of the patients, this is the key, in vast majority of the cases will treat it non-operatively with physiotherapy, exercise, strengthening. Now, where are the exceptions? The exceptions are, in my books and generally accepted, is the military personnel and professional sports players. So those are the two exceptions where you may wish to consider a primary stabilization even after the first episode of dislocation. The most important factor in deciding whether this patient is likely to have a recurrent instability is what is called as the ICE score. It's the International Shoulder Instability Score. Please read up on this. It's out of 10. And if there's more than 6, if it scores more than 6, then there is a high risk of recurrent dislocation. But even then, even if I see a patient who's under the age of 20, after a first dislocation, I'd always advise them and warn them that they have an increased risk of instability, but I do not offer them treatment after the first age group. Some people say that the age of dislocation, and if you add the remaining numbers to make it to 100, is what the chances of having a dislocation are. So if the patient is 20, then 80% chance of having a recurrent dislocation, but you can look at it that at least you will save 20% from having an unnecessary surgery. So I don't think after the first dislocation, primary stabilization is an indication. Important question after that is, if you decide, let's say this is a recurrent dislocation, is what surgery you're going to offer. So in vast majority of the cases, although this is changing, you do an arthroscopic stabilization using a capsulolabral repair. Even if there is a small bony Bankart lesion, then you would still do an arthroscopic repair. If you're not able to do, or if if you do not have the expertise, then doing an open arthroscopic, an open Bankart repair is still an acceptable thing. Important to know is when to use a bony procedure, i.e. a latter J type of procedure. The exam answer is when there is 20% or more defect of the anterior and anteroinferior glenoid. Then you would do a bony procedure. If there is a recurrent instability after initial stabilization, then it may be a slightly softer indication to do a bony repair. But again, from the fellowship point of view, I think if you're going into that territory, that means you've gone beyond pass, and as more discussion to whether to give you an 8 or something like that. for practical purposes, even in patients who have recurrent instability after initial arthroscopic stabilization, if their glenoid loss is less than 20%, I would still offer them an arthroscopic repair with the understanding that they have a higher risk of failure, but at least you're not burning any bridges by doing a bony procedure. Now, the bony procedure is not without its downsides. It is a major intervention, especially if you're using the coracoid transfer. It makes the shoulder more problematic and difficult for future in the sense that, A, you remove the landmark. The coracoid process is called as the lighthouse to the shoulder. You've removed that. There is so much scarring around the front of the shoulder. So if you have to go in to the shoulder again, then you're more likely to find problems with that. So I've actually moved away from using the coracoid. I generally tend to use iliac crest as a bony band for a bony procedure. So 20% glenoid loss is the right answer. If you're going into further discussion, it discussed about the on-track and off-track Hill-Sachs lesion. But again, I think that's beyond the requirements for the fellowship exams. Hitesh, shall we do the rest next time?
Yeah, perfect. We have covered a lot of topics. I think it'll be quite enough for this time.
Okay.
And a couple of questions actually.
Yeah.
One is, what is the, someone wants to know what is the inverted pier glenoid?
Okay. So if you imagine a pear, okay, so on the pear, let me just draw one. So this is a very rough diagram. So that's, let's say, the shape of a glenoid, not exactly like that, but roughly. That's the top, that's posterior, that's anterior. Now, when you start to get more dislocations, the patient starts to wear off the glenoid from the front here. And once that goes off, if I just put this here, you can see the shape of the glenoid has changed. And that's why it's called as an inverted pear shape. I've tried to draw one there, but not quite right. But I just think that this is gone, and that's why it's called as an inverted pear. So upside down like that is what it appears.
So it indicates a glenoid bone loss, right?
It does indicate, yeah, if you've got a patient with inverted pear shape, then yes, that's a significant bone loss. Now, I forgot to mention the other way to assess, so that can be a question in the exam as to how do you assess the glenoid bone loss. Now, the two methods that I described, the circle, measuring the perfect round circle on the on-fast view. Maybe next time when I'll show that. You draw, and that's how you calculate the loss. The other one is when you're doing an arthroscopy, you measure, there is what's called as a normal area, bare area in the glenoid. And you measure that, how much is in the front and how much is at the back of the bare area. Usually it should be equal, or maybe a touch slightly smaller on the anterior side, but that's another method of assessing the glenoid bone loss.
Okay, so when you have a inverted pear, your treatment is more likely for a bone graft, right?
Bony procedure, yes.
Okay, and you prefer ICBG, the iliac crest bone graft?
I do prefer iliac crest bone. I started with doing the coracoid transfer, but having spoken to people who actually do revision of failed latter J, so what couple of them have said is that, remember, when you do the coracoid transfer, what you're doing is you're moving so that's the subscapularis. You split the subscap, and you move the coracoid with the conjoint tendon here, what it does, it almost kind of, can you imagine what's happening with the
Scrapes through.
that's correct. It makes the bottom part of the subscapularis avascular or less vascular. So what they say that functionally that part of the subscapularis is just, you can imagine it's not there. That's what they say. You've got to treat it if it's not there.
I've done a few lethargy in recent times. I need to look at them, how they're performing. In the initial first 6 months, they're doing fine. But like you said, later on, they may have a, deficit in internal rotation if your subscap problem arises.
It's not a procedure without, even in ones done very well, it's not a benign procedure. You see, even if the patient has got rid of their instability, it will have consequences.
But I think the biggest advantage is the less recurrence rate with lethargy. Don't you think?
I agree. Look, it's definitely the answer, but whether that is the answer for everybody, I don't know, because this now people have, so to reduce the size of the graft that you use, people are now moving on to doing arthroscopic ones. So there you can use slightly smaller bone graft and less tissue damage at the front. And I think with better instrumentation, the arthroscopic latter J will become more prevalent and more common. I'm not somebody who has the patience to do all those things. So I can't see myself, not today, I can't see myself doing an arthroscopic latter J.
The other question, actually the questions that have been asked are slightly higher, not what they have expected for the fellowship. Someone wants
you can ask me.
The remplissage procedure.
Okay, remplissage procedure. Again, if you look at fellowship exams, if you're asked about remplissage, you're passed. Okay, now remplissage is basically to fill in the defect in the Hill-Sachs lesion. And what my understanding, having been to lots of meetings, is it's more of a European technique.
French.
When I say European, that excludes UK, yeah?
French, right?
Yes, it's more of a French procedure. So this side of the English Channel, so we don't use that much in the UK. It's more of a French thing. Again, whether it helps or not, I've never done it. I probably count on my hands how many I've done in the last 12, 13 years. Remplissage procedure is technically demanding. You don't know, unless you are very good at it, the chances of making it worse are causing problems is more. You will reduce the rotation as well as the same time. And remember, any extra bit of metal or whatever anchor you're putting, you're exposing the patient to that increased risk.
So how do you address a large Hill-Sachs?
So if it's a large Hill-Sachs, and if you're worried about the engaging Hill-Sachs lesion, then you seriously need to start to think about doing a boning procedure.
And do you want, for example, do you do a lethargy, and how do you address the defect in the humeral head? Do you graft that as well?
No, I've not done one, and so I wouldn't be able to tell you what you do. And again, it's not something that's done commonly. It's not just for the fellowship. It is not required for the normal or average shoulder surgeon.
Okay. Because that's what I told you. All the questions that have come up in the box are advanced level questions.
Answer as much as I can. I may not have all the answers.
Okay, fine. And again, someone wants to know, suppose you have a patient with a habitual dislocation of the shoulder.
Yeah.
How do you offer them surgery at all, or you have any different approach?
So for practical purposes in UK, they are all, so we are regional based. So for us in the south of England, we send them all to Stanmore, which is the regional center. And what they do there is they do an intensive inpatient rehab. And it's not just musculature rehab, they also have psychotherapists and what is the term they use?
Scapular dyskinesia.
Scapular dyskinesia. They do sort of feedback. There's a nice term for that. I forget.
Proprioceptive feedback.
Proprioceptive feedback and all that kind of things they do. And even in there, they generally tend advise to avoid situation where they are getting in a position, if they can avoid that situation where the shoulder is going to dislocate. Again, doing any bony osteotomies is not something that I've seen or heard being done commonly. If there is again, and that's why that Stanmore triangle is quite important, is that although they may start off with what we describe as a laxity or habitual, they may have a minor trauma. And if there is a traumatic lesion to that, it may make the patient who was doing okay and make that unstable. So you would go and repair that capsular labrum in that situation.
Yeah, I remember the triangle where one can go to the other one.
Correct.
It can shift to the other group.
Like your orthopedic principles triangle, yeah.
Yeah, because Stanmore classification of shoulder instabilities, I mean, it's quite a good concept, because I think it's only recent. It wasn't there before, because we all learned with what Frederick Mattson said about Tubbs and Ambry.
That's correct. That's how, yeah, it's becoming more relevant now, and people are trying. I mean, it's been there for at least 30 odd years, but it's not been publicized that much.
It's not highlighted, but of late, I think in every meeting there's a discussion on the Stanmore classification.
Because there is a chunk of patients who don't fit on either of them. So you don't have the classic traumatic or the classic atraumatic one. Yeah.
Okay. I think that those are all the questions that we had. Okay. And
so, yeah.
Everyone is concerned about instability.
In what way?
Yeah, there's one more question actually. See, there was a paper in the JBJS American which said that the results between an open surgery and an arthroscopic surgery are quite in par. So what is your take on that? So I remember I listened to that, you have said that, okay, open surgery is quite good, but are you concerned with high recurrence rates in arthroscopy?
Okay, again, you've got to go into details of the recurrence rate. Now, in the arthroscopic surgery, you're more likely to take a chance on somebody. So say, for example, if a patient comes to me, a 20-year-old with instability, and when I look at it, I'm sitting on the fence and whether this patient would be a candidate for a bony procedure or an arthroscopic procedure. And on balance, you decide that, okay, let's give this patient a chance with the arthroscopic procedure because he's got little morbidity in vast majority of the cases. And that may explain why there is an increased risk of instability, that you probably, the case mix is slightly different. I can't remember that paper, but whether there is a difference in the case mix in the two, and you're likely to include more of those on the arthroscopic ones than you would do for an open one. That is one explanation.
Because there's a lot of emphasis on the gift, get it right first time.
That's correct. That's correct.
So that's what someone has popped up that question. Yeah. And I think that's quite enough. We have covered almost a large amount of topics on relevant to the shoulder today. And I think we can do the next session whenever you're ready.
So what I was going to suggest, Hitesh, as I was doing this, maybe I don't know what you feel about examination.